If your patient's heart is tired, but you still need a boost, Dobutamine may be your friend. So we talked about some other drips that have good inotropic effects like Dobutamine, such as epinephrine, but we know that they also come with some vasoconstriction, and some of our patients, they can't tolerate that, or you may have the patient already on one of these medications and you're still seeing by the numbers on your hemisphere that your patient's cardiac output is still trash. What are we going to do in that case? We may add Dobutamine. My name is Leah. I've been a CVS nurse for 18 years. Let's chat about Dobutamine a little bit. So why use Dobutamine? It's a great drug for a patient that's in cardiogenic shock, but that cannot handle more vasoconstriction that some drugs like epinephrine might cause. So we use it whenever we need a patient's contractility to increase without their vasoconstriction increasing. Dobutamine is a great inotrope, but all inotropes have some things in common, and that is that they can cause tachycardia. So you really want to be watching for your heart rate, and you want to make sure that the rhythm stays the same as well. It's not uncommon to see AFib after you start Dobutamine, which is why some people are hesitant to use it. But in the right patient population, it's a great drug of choice. We also see with Dobutamine, right whenever you start it, you may experience some hypotension. For the first 30 minutes or so is what I usually see at the bedside. I see that as we add the Dobutamine, I may actually have a little bit of a drop in blood pressure, and I'm usually already on some pressors, and I try to give that a little bit of time to work itself out before we say like, oh, this drug isn't the right one, it's not helping. Dobutamine is an inotrope. It's going to increase your patient's contractility. You're going to watch your patient's heart rate. You're going to watch your patient's heart rhythm, and you're going to make sure that you have some sort of monitor where you can see that the patient's cardiac output is improving. We usually start at doses of around 2.5 mics per kilo per minute, and then go up to 5, maybe 7.5. At our facility, if you want to go above 7.5, you need to contact the provider. Usually keep it in the lower ends, even though it's a titratable drug for us. But every facility is different. Know what your protocol is at your facility. But 2.5 is usually the starting dose as most places I've worked. 5 is a very normal dose as well. Once you start getting above 7.5, just know that the provider should probably be involved in that decision. So continue to follow along with this series. We're going to cover some other medications and IV drips in the ICU setting. Follow, like, and share with your friends.